the issue is that we are used to the fact that we have clean water coming from our taps, that if we buy foods in whatever supermarket stores and so on, we are basically sure that it's clean and safe. We are not asking even how it is done, what procedures are, that's what it is. But in terms of air, no one takes responsibility for the air, and it's kind of accepted that the air could be of whatever quality containing viruses and pathogens and so on. So the key message is really air should be treated like everything else, and we should expect clean, polluted, pathogen-free air in our shared environment.
What has been the major challenge to clean air, pathogen-free air indoors?
Well, firstly, how it did happen that we have clean water, because it was a major focus on this in the 18th century, and there were people who were working on this, and this changed the policies and regulation standards around the world. But there was no push like this for clean air, and clean air is much more difficult than water, because if water coming to our taps comes from a specific source, so if you assure that that source sends clean water and that on the way the piping is right, so then water will be clean in our taps. But with air, it's much more difficult because there are the individual indoor environments, individual sources like we humans there. There's endless number of options in terms of the ventilation, natural versus mechanical, and activities, number of people, and so on. So this is more difficult. And well, simply didn't get to the agenda of the public health authorities. But it didn't because the main body which should have been sending this message, which is WHO, hasn't been sending this message. Hasn't been sending this message before. And during the pandemic, as we've discussed before, has been sending a true wrong message, that the virus is not airborne. So therefore, since it's difficult, so public health authorities were claiming, well, we don't have to worry about this. That's how
but even our local infection control committee, I looked at their recommendations, and I don't know if you saw those. This is the committee that's chaired by Lynn Gilbert, and they still recognize droplets as the major form of driver of transmission, and they see fomites as being even more of a concern than aerosols, which quite frankly, how is it that we're in now, May 2021, we've seen so many examples of infections that can only be explained by aerosol transmission in hotel quarantine situations, and yet we're still, sticking to this rigid thinking that it's mostly droplets. I'm confused.
Well, the WHO step by step is modifying the language and trying to do it such that no one notices, not to be seen that they've changed 180 degrees. So this first happened after our open letter last year in July. Then there was another update, and there was a new update a few days ago, last week. So WHO is almost there, but not quite. Because if you've seen this latest update, as I said, there was no press conference, it was very quiet about this. And so hopefully nobody notices this. So, but what they say is that the majority of the infections occur within 1 meter. But they say that inhalation, that it can be inhaled, which they were not saying, but the majority within 1 meter. There's no evidence that it's 1 meter, and there's nothing magic about this 1 meter. It's continuity. Like from any source, the highest concentrations is next to the source. So the closer you are to the source, and the shorter time is sufficient to inhale more. But as you are moving away, the concentration decreases. So perhaps you need a little bit more time. But as I said, nothing changes after 1 meter whatsoever. So, but it's just that 1 meter stays there just to kind of in gradual transition from the previous that 1 meter is. So that's what they have to still change. And the qualifier that it is in crowded and poorly ventilated places. Well, this is true, but stating this puts that image, crowded, poorly ventilated place. You imagine a bar, like crowded bar. We are next to each other, and poorly ventilated because air can't move between the patrons. But the problem is that an office like this here, if there are 3 people here, it's a crowded and poorly ventilated place from the point of infection transmission. And no one looking at this office here would say that this is a crowded and poorly ventilated place. So putting this qualifier just sends it on the wrong sort of thinking. And the public health authority would say, yeah, well, no, most our shared indoor modern spaces they are not crowded, poorly ventilated, so it's not a problem. So removing this 1 meter and removing this qualifier, we are there. So it's slowly changing, and CDC also changed something. I think overnight something came. I haven't sent, haven't had it. They've been changing. I haven't read the latest version. So it's step by step it's changing, but it is happening this sort of quiet, without any major things, and National Public Health Authority opt not to notice this.
So how much input have you had in terms of identifying which hotels and hotel rooms might be better suited for hotel quarantining than others? Like, have they brought in people like yourself for expert advice?
No. I was contacted twice by Queensland Health in relation to this. So we had a conversation. They took notes. I was going to be invited to brief them, and nothing ever happened. These guidelines, in Australia at least, are not designed in consultation with scientists. So, no.
That is for me as a tax-paying citizen, my biggest frustration that, we keep on hearing that we've got to stick to the science, but the scientists are not getting, able to put their expert opinions forward for consideration.
That's right. Now, we've written last year, we've written to the Minister for Health, we've written to the Chief Medical Officer. I mean, there were several organizations, and of which I was part. There have been other similar petitions written, which I've seen by other people. They have a template to which they reply, because I've seen the reply. So it's basically the same template, just grab the paragraphs, and basically they are saying that everything is done properly, not to worry, and completely ignoring this. They've been called to include me in particular in this advisory body to the government. No, this never happened. So considering that I've been the most sort of recognized experts around the world about this, the fact that in Australia no authorities want to include me, it's just showing the authorities are afraid of science, as a matter of fact.
It really does. If it wasn't so serious, it would be a complete joke, but it really is serious. So it must be incredibly frustrating for when you read these reports of like hotel quarantine workers like opening up the door and of someone who's obviously infected and then getting infected. Like these positive pressure rooms are just ridiculous. Do you have any thoughts on what would be the best sort of model for hotel quarantine for the sorts of rooms that we would need to put people?
Well, they've been. The issue is that right now there's a very big mix of what's being done. So mix of different hotels, different types of hotels. Each hotel is designed differently. So these are not facilities which were designed with this specific thought. So therefore, there's no one a kind of prescription, do this, and this will be fixed. Every facility has to be looked individually. For example, if there is positive pressure in the rooms in one hotel, means that one clear sink, it shouldn't be, because if positive pressure means that it leaks outside. It's got to be negative pressure. If there's negative pressure, but something else is to the flow in a different hotel, this should be looked at. So general guidelines like this, which would have a checklist for all the options, can be developed, but hasn't been, because the authorities didn't want this, or try to deal with this themselves. You also said that it must be frustrating for me, and actually I had an interview an hour ago, and the journalist also asked me that it must be frustrating for me. Well, it's more than frustrating, because frustrating, okay, we are frustrated with all kinds of things, but it's horrifying, because this has an implication on people's lives. How many lives, how many millions of lives could have been prevented if right straight from the pandemic ventilation was included in the discussion? So this is criminal, basically.
Well, it's terrible neglect. Can you outline 5 things that you would like to see governments do, or at least the WHO recommend?
Well, the first is that's what we are calling for the paradigm change. Paradigm change that air in our shared places should be clean and with concentration of any pathogens minimized to below the risk of infections. This is the most important. Once this is done, then we can go through the list of how to develop such environments. And the first, you would normally first think about new designs. So new buildings, when designed, they should be purpose designed for the activities conducted there, and they should take into consideration, on one hand, what's generated there, in particular pathogens by humans, but also the fact that buildings are potentially surrounded by polluted air, like which we had during bushfires here. So therefore, buildings should be able to accommodate these different scenarios to minimize the risk of health risks, and do it in an energy efficient manner, which means such a way that dependently on what is the need, the right building operation procedure is chosen, not to, let's say, over-ventilated when it's not necessary, or under-ventilated when it's necessary. So these are basically the thing. And once this is accepted, and then recognition that the costs of infections, as we can see, or the cost of health effects, like we've seen during bushfires, which have been already quantified, because people were not able to protect themselves in buildings, are far, far greater than better design and the investments of new buildings. So that's the first. And then, of course, we're talking about new buildings, but there is these buildings which we have here, which will still be for the next few decades. Therefore, we need to look into what redesigns, what can be done to lower the infection risk and air quality in the existing buildings. And again, there are options for this. So this is this high level. From that high level, and the point is, everybody would like to see one particular technical recommendation, do this, and everything will be fixed. Well, there's no one particular recommendation, because there's such a big number of different buildings. So,
yeah. So obviously cinemas where people are sitting very relaxed, that's going to have a different requirement than a room where you've got lots of people on exercise bikes pedaling very fast in a spin class.
Yeah, exercise bikes, but even more people loudly talking, because exercising bike, it is still people breathing. So breathing through nose, through mouth. And we've quantified how many respiratory droplets are generated during this. So during mouth breathing, heavy breathing is more than nose breathing, but still is significantly less than loud speaking or singing.
Yeah, actually, I interviewed the guy. There's a really nice guy in California. I can't remember his name.
Jose Jimenez?
No, I think he's sort of gingery color, beard. Anyway, yeah, he did a lot of work looking at talking and talking loudly and things like that. And it's interesting too, now that we know that the salivary glands can be infected with SARS-CoV-2, that it makes sense that spittle could also carry, not just the respiratory secretions from the lungs.
Well, every part, particles coming from every part of the respiratory tract. But always the question is, from which part of the respiratory tract, during which activities, the majority of the particles are generated. And during speaking and singing, the quantities of particles generated during the vocal, because of vocal cord vibration is far, far bigger than the number of these big particles we can see from the mouth.
Right.
So that speaking activities, if people are loudly talking, that's something which needs to be taken.
So would you like to see like building codes change to incorporate these, requirements on better ventilation?
That's right. That's right.
Yeah. And so my understanding is that you're part of a group of scientists that has written a letter to science. Is that what's happened?
Well, we submitted the paper.
Okay. Yeah.
We submitted the paper. The paper was peer reviewed. So, and as a result of the.
Okay.
Yeah.
And my understanding too is that there is a portable, like carbon dioxide monitoring device that you take with you sometimes to understand. Can you show me? All right. Can you explain what it is and what it does?
Well, this one measures two parameters. This one here is CO2, and this is particulate matter. Now, this is a more elaborate device that people need. It's just that we have this because we've been using it for other applications. But really, this is, from the point of view of ventilation, any device which measures properly CO2, carbon dioxide, is sufficient for this purpose. So right now, actually, see, during that moment, you've been looking, the concentration increased. Do you know why it has increased? No one entered here. I'm just very close to it. So before it was standing there on the desk, and I'm now just exhaling directly to it. So the concentration is, but it doesn't represent the concentration in this room. It's just directly. But when I put it there on the desk, it's around 400 something. That's the concentration, background concentration in Brisbane. So I've been taking this, but I wouldn't specifically write to recommend this device, just any device which measures CO2. And interesting thing is that taking it to a number of places, many places, in places which I would have thought are reasonably well ventilated, they were not. Like, for example, numerous restaurants here in Brisbane. So say one big Queenslander with very high ceiling, not many people obeying the restrictions. But there was a air conditioner, but I couldn't tell whether this is a split system or whether it's a bringing fresh air. Well, clearly it was just turning around because the concentration in that particular restaurant was about 2,000, well above. So if this is the case, if there's so much CO2, infection risk is high as well. This is the discussion about whether CO2 is a perfect indicator in relation to infection transmission has been going, and it's not a perfect indicator because we've also done a little group of co-authors, we've done calculations showing that it could be a situation that CO2 is still reasonable, but infection risk is too high. But if CO2 is high, there is a clear indication that there's a problem.
Because essentially you're breathing in other people's breath.
That's right, yeah. Yeah, so if CO2 is high, means that a lot of CO2 generated by me or whoever else is in the air, and then we inhale each other's.
Do you think that this pandemic is going to get us all thinking a lot more about our own personal space and the potential for breathing in other people's air?
Well, we hope so. We really hope so. But that's why that paper which we are writing. But it's like with every pandemic, after the pandemic is over, and this pandemic will be over, like all the pandemics were, people want to forget. Okay, it's over, forget, it's not going to repeat in my lifetime. But if we don't do these things which we are saying now, next time a pandemic comes of respiratory infection, the situation will be the same. And we continue not worrying about the colds, flus, and so on, because it's very difficult to change thinking. Until the pandemic last year, coming to work, sneezing, coughing was quite all right. Nobody thought about this, completely socially acceptable. So changing this thinking, changing any human behavior, it takes time. And it really requires a concentrated effort to change this. So thinking, people behavior, but authorities' action in terms of standards, regulations, and so on.
Yeah, I always think of multi-drug resistant tuberculosis as well.
That's exactly right. This is also airborne, and this is also a problem. Yes. We are lucky that it's less of a problem in Australia, but many places it's a serious, very serious problem.
Can you tell me, Lydia, how many papers you've co-authored on aerosols and infection and the whole sort of physics of, has it been hundreds?
Well, maybe not hundreds, several tens.
Right, dozens.
Yeah, dozens, yeah, it would be dozens.
And have you written books and chapters and textbooks and things?
No, I'm not writing books and textbooks. This is a science changing so fast that no one really reads books. So the biggest contribution I can make is doing research and papers. Yeah.
Yeah, cool. Is there anything else, Lydia, you wanted to mention that we haven't covered?
Well, I think we covered everything important, and then that we need to change things for the future, and we are not going to be in that situation again.